As an industry leader in providing non-invasive home mechanical ventilation, Medical Service Company's NIV program has improved patient outcomes, decreased healthcare costs, and reduced hospitalizations. Our non-invasive home ventilator program combines specialized respiratory therapists with advanced home ventilator equipment to ensure the best possible results and improve patient quality of life. Upon receipt of a new home ventilator request, Medical Service Company's clinical team collaborates with the ordering physician to ensure the medical record supports all insurance payment criteria, ensuring that the patient has access to this life-saving equipment and care. Mutual patient-clinician interaction is paramount for therapy engagement. Therefore, within the first 30 days of starting non-invasive ventilation therapy, our respiratory specialist spends at least 5 hours of direct interaction with a new NIV patient. Along with quarterly home visits and monthly phone calls, Medical Service Company promises the patient has frequent, ongoing communication with our respiratory specialist. To learn more about our NIV program, please reach out to your local MSC territory manager or visit our website, medicalserviceco.com. Thank you.
Our second speaker in our respiratory lecture series today is Dr. Roger Johnson. Dr. Johnson received his undergraduate degree in biology from the University of Illinois and was a graduate of Northwestern University Medical School. He completed his residency program and was chief resident at Vanderbilt University Medical Center. Currently, Dr. Johnson is the medical director of the intensive care unit at St. Mary's Medical Center in Evansville, Indiana. He is also chairman for the Critical Care Committee and Protocol Review Committee at St. Mary's Medical Center and is a board member for the St. Mary's Medical Center Foundation. Dr. Johnson is passionate about research and teaching. He has been first author and co-author on over 10 publications, has presented on numerous occasions, and is currently an instructor for the American College of Surgeons Committee on Advanced Trauma Life Support course and instructor for the Society of Critical Care Medicine Fundamentals of Critical Care Support course at St. Mary's Medical Center, teaching faculty at Indiana University Medical School and teaching faculty at Indiana University Southwest Internal Medicine Residency Program. Medical Service Company would like to thank Dr. Johnson for speaking for the first time as a part of our JSM Memorial Education Forum. We hope that you enjoyed this presentation today. Treatment of severe COPD and emphysema with endobronchial valves beyond medical management. If you have any questions for Dr. Johnson during this lecture, please use the Engage tab. Don't forget to complete and submit your evaluation form after each lecture.
Hello, my name is Roger Johnson. I'm a pulmonary and critical care physician at St. Vincent in Evansville, Indiana. And today I'm going to be talking to you about a new treatment for severe COPD and emphysema, specifically Zephyr valves, which is a form of endoscopic lung volume reduction surgery. We'll have some time at the end for questions and hopefully you'll enjoy it. So here's our agenda today. This is obviously an innovative technology, as you'll see. It's very state-of-the-art, and we've been doing it here at St. Vincent for approximately the last 2 years. But I'll go through the timeline a little bit with you as far as globally. So we're going to talk about the problem of severe emphysema and hyperinflation, talk about a new treatment option, the Zephyr Valve, review some of the key clinical data from multiple clinical trials. We won't get too deep into the data, but I'll hit the very high points. And a very important question is which patients are eligible for this treatment. So the first thing is the problem of severe emphysema and hyperinflation. So emphysema is a severe form of COPD or chronic obstructive pulmonary disease. It is a progressive disease and leads to destruction of the lung tissue. That leads to air trapping, which causes persistent breathlessness. The patient has to sort of breathe at elevated lung volumes, which puts the respiratory muscles, especially the diaphragm, at a disadvantage, and it increases the breathlessness of the patient. So this is a slide that talks about more about air trapping and hyperinflation. Obviously, emphysema, COPD is among the leading causes of death worldwide. In the United States, it's estimated that COPD is associated with approximately $49 billion in direct medical costs, and that is in 2020. Obviously, there's indirect costs as well, lost wages, lost time at work, lost productivity, but this is just direct medical costs. Prognosis for COPD can be, as well as quality of life, can be worse than certain patients with lung cancer. So on the right side of the slide is an illustration of healthy lung. It shows that the tissue is elastic with large surface area. Breathing is easy and effortless. The lung expands and contracts normally. And then on the lower part of that section is the lung with emphysema. There's tissue destruction that reduces elasticity and compromises gas exchange. And because of that, air is trapped in the diseased portions of the lungs, which increases lung volume and puts pressure on the diaphragm, and again, puts the diaphragm and the respiratory muscles at a mechanical disadvantage. So hyperinflation, we have found, is one of the key drivers of symptoms and mortality. And you see on the left part of the slide, kind of a Kaplan-Meier curve that shows cumulative survival. And you can see the bottom part of the graph, the bottom line, is more hyperinflated patients. And that's defined as an inspiratory capacity over total lung capacity of less than or equal to 25%. And you can see patients who are more hyperinflated have much lower survival over time than patients who are not. Those patients also have a worse quality of life. They have higher baseline dyspnea, significant intolerance to exercise. They have lower peak oxygen uptake, lower daily activity levels. They're less able to do things, less able to do their activities. They tend to have low BMI or muscle strength, and they do have reduced cardiac and circulatory function as well. So lots of negative effects of this. So looking at lungs of COPD patient versus a normal healthy patient, and this is height and age matched controls versus COPD patients. So on the left, you'll see the X-ray of the healthy lung. Inspiratory capacity is about 3.3 liters. And you can see the total lung capacity and functional residual capacity below that. You see the patient with significant COPD, emphysema, air trapping, and hyperinflation. Their inspiratory capacity is only 1.2 liters. So they're much less able to take a deep breath, essentially. Their total lung capacity is much increased, and their functional residual capacity, which is where the lung rests at the end of a normal expiration, is almost twice in this patient what the healthy age and height matched control is. So these patients definitely have deranged physiology, and that's where we try to target. So progression of disease with COPD, it starts with hyperinflation and shortness of breath. The patient gets decreased activity. Because of that, they have reduced exercise capacity and increased breathlessness, which is a vicious cycle, leads to further decreased activity, further deconditioning, and just continues to go on sort of in a circular pattern, and things just get worse and worse and worse. And then obviously, as the disease progresses and toward the end stage of the disease, then the patient has a higher risk of mortality as well. So what about the Zephyr valve, which is the new treatment option we're going to discuss today? There are several treatment options, and they're kind of on a spectrum or continuum from less invasive to more invasive. Obviously, on the less invasive side are oxygen therapy, corticosteroids, bronchodilators, inhalers, things like that. Pulmonary rehabilitation, which is important, but obviously is not an invasive treatment. And then we have the more invasive, ranging from lung volume reduction surgery, and that's surgical lung volume reduction, to lung transplantation, which is obviously very invasive and very complicated and burdensome to the patient and their family. So a lot of patients obviously would like something sort of in the middle. What about, something that's, bridges less invasive and more invasive? And that's where the Zephyr valve comes in. So this is was approved by the FDA for severe emphysema patients. That's what it looks like, much magnified. It's a tiny implantable device. It is fully removable. The benefits are similar to lung volume reduction surgery without having to do any cutting or actual surgery. The patient selection is very precise, and also that's probably the most important part of this whole process is actually selecting the right patient. It's obviously proven in multiple clinical trials and is included in the most recent guidelines, including the GOLD guidelines, and as I said earlier, fully removable. So this, hopefully, the Zephyr valve will act as a bridge between less invasive and more invasive options. So a lot of patients are very interested in having something else. They've tried the oxygen therapy, corticosteroids, bronchodilators, pulmonary rehab. They're not quite ready for lung transplant or lung volume reduction, but the Zephyr valve is kind of a nice intermediary between those. So this is a video of how the valve is placed and how it works. So we place it with a flexible bronchoscope. We usually pick a target lobe to treat, and that's the deploying catheter. And it actually is sort of extruded there from the catheter. And it's a one-way valve, so it lets air out of the treated or target lobe, but will not let air back in. You can see an actual bronchoscopic video on the bottom right there that shows the valve actually opening and closing. And letting the air out, but not letting air back in. So the overall effect you can see is deflation of that hyperinflated lung and lobe, and actually that more healthy tissue, more healthy lung is able to expand and have more room to actually do a gas exchange in physiology. So it essentially collapses this diseased, air-trapped, hyperinflated lobe and allows the more healthy lung to expand into that space and work much better. Also changes the configuration of the diaphragm so that breathing can be much easier for the patient as well. They get a better inspiratory capacity, less hyperinflation, and air trapping. So that's just a quick overview of how it works. So what are the benefits of placing Zephyr valves? Obviously, I've shown you, a graphic, but what does that really look like? So we have improved health status, which we use a index or a questionnaire called the Bodie index. We have improved quality of life, and there are different ways to measure quality of life in COPD, the St. George Respiratory Questionnaire, the CAT score, COPD assessment test, and also a 6-minute walk distance. You get less breathlessness, so that patients are able to do more and with less shortness of breath, and that's like the MMRC or Borg dyspnea scale. You do get improved lung function, including FEV1, DLCO, FRC. You get reduced gas trapping, including residual volume and total lung capacity, and a better inspiratory capacity to TLC ratio. And then you get a total lung volume reduction. So you get successful lobar occlusion and you get lung volume reduction. So these are all the benefits we can see. So as I said earlier, I alluded to this, a lot of patients with emphysema and COPD who are, very symptomatic are wanting something. There's got to be something else. So this is a questionnaire of the preferences that show a choice between, basically, are these patients wanting something more? So there's 294 U.S. patients with severe emphysema, and they 76.4% of them said, yeah, I'd like to try something else. So over 3 out of 4 of them would select, let's try Zephyr Valve instead of continuing to do what I'm doing. Of course, it's not for everybody. There are patients that say, yeah, that's a lot. I don't know that I want to commit to that, or I don't want to go through all that. Those types of things. We'll talk about the process a little bit later. But the vast majority of them do want another option. They want something better, something else. And we've actually had patients call our office looking, do you guys do Zephyr Valves? I had a patient actually show up in endoscopy asking about Zephyr Valves. Do you guys do Zephyr Valves? So people will seek this out. There are a lot of people that are on, different types of support groups and Facebook groups and things like that that have heard about this. That they're friends on the group talking, and you heard about the Zephyr Valve. So there's a lot of interest in it, which is very exciting and appropriate. So briefly, we're going to touch on key clinical data for multiple trials, and I'll go through the sort of evolution of how this treatment came to be and came to advance to the level it is today. So the first big trial that we had was actually in surgical lung volume reduction, and that was called the NET trial. That's National Emphysema Treatment Trial. That was done starting in 2001, and it was published in 2003 in New England Journal of Medicine. That was a big, pretty big study that really showed the benefit of surgical lung volume reduction for these patients. Obviously, those patients underwent surgery, so and they're very carefully selected. They're only done at certain centers, and so then we went and had several other studies done with Zephyr Valve specifically, starting in 2010. There were several studies, the VENT-2 study. They all have fancy names like the cardiology studies, Believer, Stelvio, Impact, Transform, and Liberate. So this has been extensively studied. And the National Emphysema Treatment Trial, of course, was basically you had to have heterogeneous disease, mostly upper lobe treatment. So the upper lobes were what was treated. Okay, the VENT-2 study was upper and lower lobe treatment. So when you start using the valves, you can actually target other lobes. It doesn't just have to be the upper lobe like for the surgical LVRS. The Believer study, we advanced there and we used upper and lower lobe treatment, but also we started to recognize that patients who had more complete fissures on CT scan had better outcomes, because what can happen is there can be collateral ventilation between the lobes. So even if you block off the main airway, that lobe is still getting air or aeration from the other lobe through that incomplete fissure. It's like closing the front door and leaving the back door open, so to speak. And so we started, becoming more sophisticated on which patients exactly do benefit from this. And that started advancing. The next study was called Stelvio. We did do upper and lower lobe treatment at that time. And also the addition here was that the patient had to have, during the procedure, they had to be confirmed to be CV negative, which is collateral ventilation negative, by a system that we use called Chartis. And what it does is it occludes either the target lobe or the other combination of lobes to make sure that once you occlude, that there isn't, flow coming from those, collateral ventilation areas through the lung parenchyma itself. And so nowadays we actually not only look at the fissures by CT scan and analyze that, but we also confirm before we place the valves during the procedure. Before the valves are placed, we confirm that the patient is CV negative or collateral ventilation negative by this Chartis technique before we will actually place the valves. Because if we place them and they're CV positive, they will not benefit and can actually get worse. The next trial was Impact 5. The other thing I didn't tell you about Stelvio is they treated homogeneous and heterogeneous disease in that study. Impact also did Chartis confirmation, upper and lower lobe treatment, but was for homogeneous disease. Transform, similar to the others, heterogeneous disease. And Liberate, which is the most recent study, was also for heterogeneous disease. So we've got data that treats homogeneous and heterogeneous disease, upper and lower lobes, and the fissures are confirmed by CT scan, and they're collateral ventilation negative by this Chartis procedure we do prior to placing the valves. So a lot has happened since we started, thinking about lung volume reduction back in the early 2000s, in the late 90s, really. But the clinical trial was in the early 2000s. So obviously, there's a bunch of different patients that can benefit from this, as we talked about upper and lower lobes, homogeneous and heterogeneous disease. And then again, they have to be collateral ventilation negative in order to receive the valves that we confirmed during the procedure before placing the valves. So what about data from the trials? So this is from the Vent and Believer trials. So we see, and this was important because we see that all treated patients didn't benefit as much as the collateral ventilation negative patients. So the key learning point there is patients that don't have collateral ventilation have a greater improvement. And in the Believer trial, we also saw that the mean change in FEV1 from baseline was much higher in the collateral ventilation negative patients than all comers. So total lobar occlusion is really what's required for improvement. If you don't have that, then the patient may not get benefit. So this is a little bit more about collateral ventilation. Again, that's airflow between the lobes, usually, sort of channels that bypass the normal airways. And there's, anatomic proof of this that we've seen. And again, only lobes without collateral ventilation should be treated with the Zephyr valve. So you see on the left, you see those two, that's the left lung. You see the upper lobe and the lower lobe appear to be separated. That fissure looks complete. There is no collateral ventilation. There's no ventilation between the lobes, whereas the right side of the figure also shows the left lung, upper lobe and lower lobe, and there's what seems to be channels or pores or communications between those two lobes that allow air to pass between the two, and that will actually negate your treatment. So that's a CV positive or collateral ventilation positive patient. And we would pick that up with the Chartis procedure. We may even pick it up ahead of time on the CT scan if the fissure isn't complete. And that's what the CT analysis shows. But we would definitely pick it up before placing the valves on the Chartis procedure. So this is there's two ways that we really select patients. The non-invasive selection with analysis of the CT scan is top left, and that's what the report looks like. It's anonymous, so you anonymously upload the study to a server. It's given a number. You have to remember the number because the website doesn't know who the patient is. So when we upload these, we actually keep track of what number the patient was assigned when we uploaded the study. And so what you'll see, and I'll try to get the mouse going here, is you'll see two big things that we look at. One is how destroyed each lobe is. So this is the right side. So you have an upper, middle, and lower lobe. And on the left, we have an upper and lower lobe. And also how complete the fissures are. And I don't know how well everybody can see this, but the solid black line is a greater than or equal to 95% fissure completeness score. So the chances that the fissure is complete is over 95% with this dark. And then the dotted line is less than 80%. So that would be somebody that would be very likely to have be CV positive between the upper lobe and the middle lobe. The other thing we look at like I said, is the destruction. So the darker the color of the actual lobes, the more destroyed they are. We look at two voxel densities, negative 910 Hounsfield units and negative 950. 950, they think, is a little bit more specific for emphysematous damage. So we really look at both of those numbers to see how destroyed they are. And when you choose a lobe, we try to choose lobes that are more destroyed. So the optimal lobe to do here, just from a destruction standpoint, would be the right upper lobe. But again, you'd have to probably take the middle lobe as well, because there's probably collateral ventilation between these two. We could also target the left upper lobe. It's not quite as destroyed, but also would give benefit. The other thing we look at is how big these lobes are. So how much benefit would we get if we occluded one of these lobes? So if we occluded the left upper lobe, for instance, then there's 2,259 cc's of volume in that lobe. So you would get most of that back, not all of it, because the lung doesn't completely collapse into nothing. It collapses into an atelectatic lung. But the right upper lobe would give you 1736, et cetera. The second way we assess the patients for collateral ventilation is to use the Chartis system, and that's the box that you see there. It basically simulates treatment with the valves and measures airflow and pressure to assure that if we occlude the main airways, that you don't have flow from other locations between the lobes. So that's basically how we'll do it.
The pulmonics Chartis system provides precise pulmonary flow and pressure readings, allowing physicians to assess the patient's collateral ventilation. By identifying diseased lobes with no collateral airflow, physicians can optimize the valve placement for endoscopic lung volume reduction.
So that's the Chartis procedure itself. This is what it looks like. So if we don't have collateral ventilation, you see kind of the flow just continue to drop as you essentially it vacuums air out of the lobe. This is a patient with collateral ventilation. So basically what happens is you're trying to suction all the air out and it's just not coming down. So this is would lower the chances of a successful treatment, whereas the upper one gives a high chance of treatment success. So here's the Stelvio study, and there were 84 patients with homogeneous and heterogeneous severe emphysema on CT scan, likely with complete fissures. And then 68 were confirmed to be CV negative by Chartis and would likely respond. So we saw several things that improved. This is the control group. This is the endobronchial valve group, and this is a crossover group that basically allowed the patients to go from the control group to the endobronchial valve group. So what you see here is what happens to FEV1. This is with standard treatment. So it in the control group, it went up 24%. 6-minute walk test distance went up 6%. All of these patients are in pulmonary rehab, so that some of this effect is from that. Same with the St. George Respiratory Questionnaire. A lower score is better, so when you see improvement, that's good. But the patients in the endobronchial valve group had much better improvement compared with the control group. 72% for improvement in FEV1, 87% for improvement in 6-minute walk distance, and 79% improvement in St. George Respiratory Questionnaire. And the MCID, which is minimally clinically important differences, is shown on these little blue lines. So you can see that these patients greatly benefited compared to the minimally clinically important difference here. And then the crossover group had similar, as you'd expect, similar success. So again, the CV negative patients have improvement in lung function, exercise capacity, and quality of life, and there's good outcomes in both homogeneous and heterogeneous disease. So what about the impact study? So the primary endpoint here was mean change from baseline and FEV1 at 3 months. And then so this is compared as a one-to-one randomization between Zephyr Valve and the standard of care. And so the primary endpoint, you saw that there was a 13.7% improvement in FEV1 at 3 months compared with standard of care, which had a decrease in FEV1. We also see the secondary endpoints also changed. So the Zephyr group is in the blue squares, the control group is in the light blue circles, and then there's a between group difference that shows the change, the total change between the groups. So you can see for 6-minute walk distance, there was much better results in the Zephyr group. Same thing with FEV1, MMRC. Again, that's lower is better. St. George Respiratory Questionnaire, same thing, lower is better. Residual volume, we want to see that decreased. So that shows less air trapping. So the Zephyr group definitely had, an improvement in residual volume as well. So that's confirmed efficacy across homogeneous patients with emphysema in primary and secondary outcomes. The Transform study had 97 patients with heterogeneous emphysema on CT and were collateral ventilation negative. This is a 2-to-1 randomization between valves and standard of care. Secondary endpoints, very similar looking data, 6-minute walk distance, FEV1, St. George, Bode index, residual volume, all greatly improved in patients who had the Zephyr valve in comparison with the control group. And again, this is confirmation of efficacy across primary and secondary outcomes in patients with heterogeneous emphysema. And then this is Liberate study. This is one of the big studies. 190 patients, 2-to-1 randomized Zephyr versus standard of care. And this is a 12-month follow-up study. So this is important because, we'd like to see that this continues to improve or the improvement continues over time. So you see the Zephyr group had 128, the standard of care group had 62. There were about half female, maybe a little bit over in the Zephyr group compared to standard of care. They're all about in their mid-60s. Their BMIs, some COPD patients have a low BMI, but these patients were pretty average. They all had a significant smoking history. This is their destruction scores. They were similar. The heterogeneity index was similar. Their FEV1s were similar. DLCOs were similar. So this is kind of the baseline characteristics. And these are all very similar, patients between Zephyr and standard of care. And so what we saw, primary endpoint was FEV1 change from baseline at 12 months of at least 15%. And we saw that almost 48% of patients treated with Zephyr had an improvement of at least 15% from baseline in FEV1, whereas the control group, only 16.8 had that. The secondary endpoints were actual absolute value of FEV1, residual volume, 6-minute walk distance, St. George, Bode index, and MMRC. So all of these look very favorable between the groups. For the primary and secondary endpoint, of course, that's statistically significant, less than 0.001. So this is looking at responder rates for some of the key outcomes, and this is basically how many patients had either a 15 or a 12% improvement in FEV1. St. George decrease of at least 4 points, MMRC decrease of at least 1, Bode index decrease of at least 1, residual volume decrease of at least 310, 6-minute walk distance of at least 25-meter improvement, and lung volume reduction of 350 cc's. So as you see at 12 months, a lot of these patients in the valve group, which is dark blue, had significant improvement compared with the standard of care. So those are all excellent numbers, obviously. So Patient-reported outcomes, also statistically significant improvement compared with standard of care, including basically some of these are functions of how active the patient is. And so basically they had better ability to do work and leisure activities in the patients who got the valves in comparison to patients who got standard of care treatment. And this is a daily diary over 12 months. Over 12 months or 52 weeks in patients with either standard of care or valve treatment. And this is change in baseline. This is an emphysema symptom intensity score. So higher is worse. So the patient's clinic definitely had a decrease in their symptom severity over that period of time, whereas patients with standard of care had, the same or some increase as well. So patients felt better in addition to all of the data I've showed you. So as far as safety, this is obviously have to talk about safety. This is an important piece because because the treatment is so good at creating atelectasis, the patients have about a 20% risk of developing a pneumothorax. So that's the biggest problem with this, and we generally are able to work through it. So if you see, this is serious adverse events occurring in at least 3% of subjects, defined by investigators. So in the treatment period, day of the procedure to 45 days, there were 4 deaths in the Zephyr group compared with 0 in the standard of care group. And then the long-term period, this is 45 days to 12 months. That was, a little lower actually in the Zephyr group, but pneumothorax was much higher, especially in the first 45 days. No patients in the either standard of care group in the shorter long-term period had a pneumothorax, where 26% in the first 45 days had a pneumothorax. Severe COPD exacerbation. We put patients to sleep and mess with their lungs. And these are patients with bad COPD. So several of them will get COPD exacerbations. In the long term, the percentage is actually higher from 45 days to 12 months. But early on, severe COPD exacerbation is higher in the Zephyr group. Pneumonia can be a complication as well, early on and late, although late is very similar to the standard of care group. Respiratory failure occurs as well, but less commonly. And the time where you generally get a pneumothorax is highest within the first 3 days. And that's why it's mandated that these patients have a 3-day mandatory inpatient hospital stay. So they all stay 3 days after their procedure, because that's when they get their highest risk of pneumothorax. Not all of the pneumothoraces require, a chest tube. Sometimes the pneumothorax is what we call a pneumothorax ex vacuo, which is basically atelectasis of that lobe occurs and it leaves an empty space because it takes time for the other lobe to expand. Those we just watch. Sometimes the atelectasis happens so fast. The valves are good at that, which is the design of the valve, what it's supposed to do, that it actually, the non-target lobe will expand quickly and actually there'll be a tear. And then those patients sometimes require a chest tube. And we actually have a way an algorithm for how to manage this. It's very complicated how you manage these, but after a couple of them, you get really experienced in how to do it. So that's the key, the pneumothorax rate. And again, severe COPD exacerbation, higher in the standard of care group long-term. Respiratory failure, again, higher in the long-term. So again, pneumothorax occurrence for most recent bronchoscopy. Again, it's highest within the first 3 days. And that's why we keep patients for 3 days. So 76% of the pneumothoraces occurred within 3 days of the procedure. And you see that a lot of them got observed, a lot of them got a chest tube, and then a significant portion also had required valve removal. So sometimes the lung will not expand enough to seal off against the chest wall, that pneumothorax, and you have to take a valve out. I've only had to take a valve out once, and so that but it does happen. And what we generally do is go back 6 weeks later and put the valve back in. So it's a bit of an art on how to manage these patients. So, like I said, all Zephyr Valve procedures are done as inpatient procedures with a 3-night stay. There are our treating centers were trained to handle the pneumothorax. The patient has a chest tube, bucket, a kit that goes with them. We kind of have that in the procedure room, and it travels with them everywhere they go to PACU up to the floor. The patient, goes down for a study, which they usually don't. That chest tube kit goes with them. We also put a little bracelet on the side that we treated. It says, risk for pneumothorax. So right away, people, and we educate the nursing staff and respiratory therapists and other physicians about this. If they had a Zephyr valve, think pneumothorax if they are having, a deterioration. Patients, of course, are also advised of signs and symptoms of pneumothorax. Also, we counsel patients ahead of time very carefully. Obviously, something that has this kind of a pneumothorax rate, adverse event rate, you really have to make sure patients understand what they're getting themselves into. So we really try to do that very carefully. So other key measures across CV negative patients. So I'm just going to really quickly look at these. So lung function and Liberate, 18% improvement, exercise capacity, 39-meter improvement. Quality of life, St. George, again, less is better, 7.1% improvement. And then we considered 84% procedural success, and this is a 12-month study. We see similar looking improvements over the other studies as well. It's globally accepted, and it's in many guidelines, the GOLD guidelines, which is Global Initiative for Obstructive Lung Disease, the UK's NICE guidelines, German Respiratory Society, Netherlands Respiratory Society, and it's evidence A for GOLD, and over 20,000 patients have been treated globally. So that's quite a bit of experience with this. So finally, let me tell you which patients are eligible. I've told you a lot about how the studies are done, what the benefits are, the risks, but which patients do we do this on? So they're indicated for bronchoscopic treatment of adult patients with hyperinflation associated with severe emphysema in regions of the lung that have little or no collateral ventilation. And I've told you how we assess that. There's different sizes of the valves. There's low profile valves that are shorter that we can put in different size airways. So the minimum criteria that we like to see for getting these patients referred to us is they have a confirmed diagnosis of COPD. Usually that means by spirometry. They're non-smoking or willing to quit smoking. We usually ask them to quit smoking for, I believe it's 3 or 6 months. I have to check on that. But they're non-smoking or willing to quit. And a lot of times, if they're willing to quit, this is sort of a little additional incentive to help people really, cross that threshold. FEV1 of less than 50% of predicted, and they're breathless despite maximal medical treatment. And that's an MMRC of at least 2. And this is the MMRC. So that would be, I walk slower than people the same age because of breathlessness, or have to stop when walking on at my own pace on level ground. So what do we really look for? So we do all of these things. So we identify potential candidates. We look at our PFT database. We also look at the database of our practice to see how many people actually meet these criteria. So FEV1 less than 50%, RV, residual volume of over 150, and total lung capacity of at least 100. And we can look at possible ICD-10 codes, the COPD, emphysema, all of those things. We definitely, we are the treating center, so we try to make connections with a lot of local primary care, other hospitals. I have several pulmonologists in my area that I collaborate with that send me these patients, and of course I send them back when this is all complete. We also go to pulmonary rehab and talk to those folks as well. That's a good population because I do require the patients to be in pulmonary rehab before treating them. The treating center, of course, we always report back to the treating physician. Was this patient eligible? Here's why not. Or if they do have it done, how well they're doing, and what we have a lot of data. We look at post-placement of the valves as well. So this is our typical workup. Obviously, this seems like a lot, and it is. We have to make sure these patients are appropriate. So medical history, they have to be on less than 20 milligrams of prednisone, non-smoking. We look at all their imaging studies. Their 6-minute walk distance should be between 100 and 500 meters. If it's less than 100 meters, they're pretty deconditioned and they don't do well. If it's over 500 meters, they don't need the valves. They can walk that far. You're good. All I can do is make you worse. Their pulmonary function tests, post-bronchodilator, 15 to 45%. The lung volumes have to be by body plethysmography. We don't use any other technique for lung volume measurement. So the RV has to be at least 175 and a TLC of over 100 for heterogeneous disease, and for homogeneous disease, the RV of over 200 or total lung capacity over 100. We do an arterial blood gas to rule out severe hypoxemia and severe hypercapnia. The imaging, we have to do it a certain way, and usually we have to talk to radiology of how to do that. We have a protocol for how to order that. We upload that to the site that analyzes the destruction of the fissures that I showed you earlier. And then we do a perfusion scan as well to decide which lobes to target. Oftentimes the destroyed lobes also have very little perfusion, but if you're between two target lobes that are essentially equivalent, you do look at perfusion to see which one has less perfusion. We do an echocardiogram to rule out congestive heart failure and severe pulmonary hypertension. So basically, this is the treatment. We take a history, lung function test, CT scan. We upload the StratX and look at the destruction score and the fissures. Step 3, once they qualify and do everything that I showed you on that last checklist, we make sure they don't have collateral ventilation. Step 4, we place the valves to completely occlude the target lobe. And then step 5 is basically post-procedure management. They stay in the hospital for 3 nights. Hopefully they don't have a pneumothorax, but if they do, then we manage that in the hospital. Reimbursement. Most patients are able to get reimbursed through their insurance company. Many plans do cover it. Medicare does. And a lot of plans that don't yet cover it are doing this on a case-by-case basis. Obviously, we have a reimbursement team that we work to make sure that the patient has the appropriate approval before doing this. So we can definitely, and the company also runs a reimbursement support program to help navigate all that, and they're very good. And I've never had a patient denied that was appropriate. So in summary, Zephyr valves have been extensively studied. There's 4 randomized clinical trials I showed you the data on. Patients treated with Zephyr have clinically significant improvement in many things, including lung function, exercise capacity, measures of quality of life. The valve treatment is established for patients with emphysema, including many guidelines globally and the GOLD guidelines as well. Most patients who qualify are able to secure insurance coverage for their treatment. And as we saw, a lot of patients with severe emphysema are looking for something else, something better. something not quite as invasive as surgical lung volume reduction or lung transplant. And this, I think, fits nicely in what a lot of people are looking for. And that's it. And I'm going to be taking some questions after this. So thank you for your attention.
Hi, it's Keith again with Medical Service Company. We're here
Hello.
with Dr. Johnson. Thank you for that insightful and very informative presentation regarding the Zephyr valves. It's definitely something I knew very little about, so it was very a lot of great information there.
Thank you.
So thank you for your time. Appreciate it and welcome. It looks like we have some questions that rolled in from the audience.
Okay.
We can get right into it if you'd like.
Yeah, sure. That sounds good.
All right. The first question that we have is, what would some reasons patients would not be a good candidate to be, to get the valve?
Okay, that's a good question. So that kind of goes back to our eligibility criteria. So in general, we don't want we want people who have a BMI less than 35. They're less stable on less than 20 milligrams of prednisone. We don't do smokers. And also, they have to meet all of the criteria we talked about. So the 6-minute walk distance, the pulmonary function test criteria, ABGs, you can't have severe hypoxemia or severe hypercapnia. And also an echocardiogram we usually do to rule out congestive heart failure and also to rule out severe pulmonary hypertension, which we define as a systolic pulmonary artery pressure over 45. Also, if they have a nodule and perhaps in one of the lobes you might target, we also wait on doing that particular lobe, because once it becomes atelectatic, you can't see the nodule anymore. So we have to follow that nodule to completion till follow-up is complete before we would put a valve in somebody with a significant nodule. Hope that helps.
Yeah, no, great. Thank you for that. The next question that came in is, what is the life expectancy of the Zephyr valve, and is it MRI compatible?
I believe it's what we call MRI conditional, which is sort of it's a vague term. I don't exactly know. I haven't run into where I needed to do an MRI on somebody with this, but that's a really good question. I can find that out for you. The Zephyr valve, ideally it can technically last forever once you put it in. In these patients, we don't take them out. Sometimes if they lose effect, so they lose benefit from the procedure, sometimes a valve can become incompetent or not be working, and you may have to revise the valve. Every now and then, maybe 1 in 10 cases or so, you have to revise the valve. But generally they're forever.
Okay. All right. The next question that we have is, are there any risks with the valve in place if a person is also using PAP, RAD, or NIV therapy?
No. Initially when you want to, as I said, the first 45 days, there's the highest risk of pneumothorax, especially within the first 3 days. That's why they have to stay 3 days. So if you're going to, you wouldn't maybe not want to put them on positive pressure or CPAP or BiPAP in the first few days after they have it. But after that, there's really no big contraindication to any of those. That's a good question, though.
Gotcha. Okay. Well, thanks for that. And the next question that we have from the audience is, you mentioned that the Zephyr valve can be removed. Under what conditions would it be necessary to remove the valve?
Okay. So the most common reason for removing the valve is if someone has a pneumothorax that will not resolve despite pretty much everything else. So conservative management, management with a chest tube, management with multiple chest tubes. I had a patient recently that had, I believe, 3 chest tubes total in all of the pockets that had pneumothorax and still wasn't resolving. So we ended up having to take 1 valve out. We usually just take 1 out at a time. Usually taking 1 out is enough to let them, re-expand that lung and seal off their air leak. The other times we would take it out is if the valve became, incompetent, or if it was, in some way damaged, or if they lost effect and we had to revise the valve. And they're very simple. Let's say you just grab it with with forceps and bronchoscopy and pull it out.
Okay. All right. The next question that we have is, if a patient does have the valve removed, what effects, if any, would the patient expect after the removal of the valve?
So with removal of the valve, they usually would lose any benefit that they had. So usually, like for instance, the patient I did a couple of weeks ago that we had to take a valve out because of a pneumothorax, he no longer has atelectasis of that lobe. So we're going to generally with patients, we need to take valves out for, unresolved pneumothoraces. Usually we will put the valve back in 6 weeks or so later. So he's going to have his valve put back in a few weeks. So yeah, so basically, if you take one of the valves out, you haven't completely occluded that lobe, and then the lobe will not become atelectatic, and that's really what we're looking for is the atelectasis of that lobe in order to promote the rest of the lung to expand and fill that space.
Gotcha. Interesting. All right. It looks like we have time for just one more question. The question that we have is, once the valves are placed, what does the long-term management look like for those patients?
Yeah, so that's a good question too. So the long-term management is usually what we do is, we have them in the hospital for 3 days. We usually see them very quickly after they get discharged, within a few days, make sure they're doing okay. If they are having any symptoms, we would get a chest x-ray just to make sure they're not having a delayed pneumothorax. And obviously, we warn these people and let them know and counsel them ahead of time that, if you have chest pain or you have shortness of breath or something you don't expect, you may have a pneumothorax. So they're very aware of that. The other thing we do is at 45 days, we actually get post Zephyr CT scan and pulmonary function tests. And what we look for there is we look to see, well, are the valves working? Is the lobe atelectatic? Is it doing what we think it's supposed to do? And also with the pulmonary function test, we also look at some of the data I showed you with the studies. We look at how much their lung volume has reduced, how has their spirometry changed, how has their DLCO changed, and that kind of thing. And what we obviously want to see is that the lung volumes have come down, both residual volume and total lung capacity. Hopefully spirometry has gone up, and hopefully DLCO has at least stayed the same. So that's generally what I look for. And anyway, yeah. And real quickly, I know somebody just asked about the MRI. So I'm looking it up on the internet, and it does say that it's MR conditional up to 3 Tesla. So I'm still trying to figure all that out. But generally, I think that means you can do it. Don't quote me on this, but I would look it up before you put someone on an MRI scanner with any kind of metal thing. That you generally, these are nitinol. They're nickel alloy, so they're generally okay. So here it says MRI conditional means the object or device is safe under certain tested conditions, and those conditions should be enumerated on the product. So it's 3 Tesla. So basically, anything less than 3 Tesla, it sounds like is safe for Zephyr Valve. But I did not know that, so I'm glad somebody asked. But yeah, so usually that kind of thing comes up when somebody has to have an MRI and they have a device. The stent, we use metallic stents sometimes for malignant airway disease, and those are also MRI conditional. And I don't know what level that gets to as far as Tesla or other parameters, but generally it's how strong the magnet is that you're exposing it to.
All right. Well, that sounds great. A lot of great questions, and really appreciate your time. And unfortunately, we're out of time. And I know that you're busy, and I just want to thank you again for being a part of the JSM Forum this year. And I look forward to talking with you again soon.
Sounds great. Appreciate it. Thanks for listening.
Thank you very much.
Take care.
Bye-bye.
Thanks.